I think the first thing to say is that the whole ethos, the whole way of communicating DNA CPR is changing, and the Resus Council are putting out new guidelines in October 2015, so they're on their way. But meanwhile, we obviously have to have a working code of practice, and I think one of the statements that the Resus Council made as to why they're looking at everything again is that considering, communicating and recording decisions about whether or not to attempt cardiopulmonary resuscitation is a challenging process, and it can result in misunderstandings, suboptimal decision making and communication failures. So that's what the Resus Council have put out. So they recognise it's a challenging thing. And they also state that it's best to consider CPR within overall goals of care. And I think that's something that I've come across now, having worked in my role for the last 5 years, is that GPs have become more confident in discussing DNA CPR, but what is lacking is the context for that. So the treatment escalation plan, or rather the ceilings of care that people want to talk about, is actually what we ought to be focusing on. So DNA CPR is just part of that ceiling of care discussion. And I think that if it's handled within that context, it's an easier conversation to have than just saying to somebody, and this is what I would never actually recommend anybody do, is say, do you want to have CPR? Because it's like you're shutting a door in somebody's face without giving them the context to why you would like the answer to that question. There are other ways of asking patients about this. As for all decisions about healthcare, the primary consideration is the patient's view, and it's helpful if the patient's nearest and dearest can be in on the conversation from the start, because I think this is where the miscommunications and misunderstandings can come, because you may have only had that conversation with the patient, and then when the crux time comes, the relative wants to know why you're not actually going to attempt cardiopulmonary resuscitation, and at that point it's a bit late to start explaining that you've had this conversation with the patient. So I think my key message is not only with the patient, but also with the patient's consent to anybody else that that patient deems is important to them. So a DNA CPR is a clinical decision based on the patient's best interests. It ensures that the decision that's made by the GP is understood in the context of the realities of CPR, not the one that's put about by the media where it's nearly always successful. And allowing this sort of open communication will ensure that the decision is understood with a mutual consensus being reached. If the patient has got really strong views regarding resuscitation, then the GP should encourage them, if they are against having resuscitation, to maybe make an advanced decision to refuse treatment so they can document it. It can be a legally binding document. Conversely, if the patient is adamant that they want to have every attempt to resuscitate themselves, then, and you don't think this would be in their best interests as the clinical decision maker, then that patient has the right to ask for a second opinion, and a GP should enable that patient to have a second opinion. The DNA CPR form should be filled out by the most senior clinician looking after that patient in the setting that the patient is at that present time. So if the patient is in the community, usually the most senior clinician is going to be the GP. So the GP is the one that should be signing this document.